Hello, everyone. This is episode 2 of Dr. Brown's Psych Commute, where I talk about interesting things in psychiatry and medicine as I commute to and from work. So, today I want to talk about treatment resistant depression as a concept and how to treat it. So, treatment resistant depression, there's no real consensus definition, but I think the most common definition that you'll see is someone with a major depression, that is major depressive disorder. So we're talking about unipolar depression when people talk about treatment resistant depression. And generally in the research studies, this excludes MDD with psychotic features. So this is unipolar depression without psychotic features. And someone who has this condition and who has not benefited from, that is, they have not gone into remission from at least 2 adequate trials of an antidepressant, a first-line antidepressant. And so what is a first-line antidepressant? So these would generally be our SSRIs, our SNRIs, mirtazapine, Wellbutrin, bupropion. So if someone's tried, say, fluoxetine for 6 to 8 weeks at a reasonable dose, maybe they were up to 40 or 60 milligrams and did not remit. And then they tried bupropion, let's say bupropion XL at 300 milligrams for 6 to 8 weeks, and they still didn't remit. Then they would qualify for treatment-resistant depression. And there are some research studies specifically in this population. There are only a couple of things that are actually FDA approved for treatment-resistant depression, meaning this has actually been studied. Spravato or esketamine would be one, and I believe, if I recall correctly, Symbyax would be one, which is the branded name of olanzapine fluoxetine combination. ECT is certainly well studied in this population, and TMS, transcranial magnetic stimulation, is specifically studied in TRD populations. But there's not most studies are not in TRD populations. So I want to talk first about, is this a useful concept at all to have treatment resistant depression and consider that as a concept? And I would argue not really. There's no evidence, and this has been investigated, that people defined as TRD, treatment-resistant depression, there's no evidence that that is a meaningful concept in terms of understanding prognosis or biology or anything like that. It really just simply refers to someone who hasn't benefited from 2 or more standard treatments. There's no evidence that it's a subtype of depression, for example. The other aspect to that is, I would also point out that our first-line treatments are just not very effective treatments. It's every few years, there's a paper arguing about whether SSRIs work at all better than placebo. I think the latest systematic reviews have hopefully laid that to rest, that they are more effective than placebos, but not by much. These are not very effective medications overall. And when they do work, there's often a high relapse risk. And that's, perhaps best reported in the STARDY study from the early 2000s, where the relapse was about 40% amongst those that did finally remit from one of the runs of that trial. So we're talking about treatment-resistant depressed patients defined by treatments that just don't work very well. It's sort of like, defining a concept of treatment-resistant UTI when you're giving people just antibiotics that are very ineffective against the bacteria that are causing the infection. So I don't know how useful this is as a concept. I think if you really think about it, um, it just points out to the fact that we've got to try something different than first line antidepressants. However, when I see a new person with depression, a new patient with depression, I'm not always just reaching for that first line antidepressant by itself. So sometimes when I'm working on the inpatient unit and I've got someone who's admitted for suicidal ideations, or they just had a suicide attempt and they're still very depressed and dysphoric, uh, I'm not going to just put them on fluoxetine 20 milligrams and wait for, slowly ramp it up and wait for 4 to 6 weeks for it to kick in when something is that severe. Oftentimes, I will go straight to an augmentation strategy. So I might start them on fluoxetine plus aripiprazole, say fluoxetine 20 milligrams plus aripiprazole 2 milligrams or 5 milligrams. And of course, I'll talk to the patient, give them those options, but I'll say, hey, this is a pretty severe episode of depression you're in. And I know you haven't tried a whole lot before this, but I think we maybe ought to be a little bit more aggressive. And usually they're on board with that because they're suffering. They're really not doing well. And in my experience, anecdotally at least, aripiprazole can start to work within a matter of days. I've seen people have significant response to aripiprazole or an episode of depression within about 4 days. So that's a game changer as opposed to waiting weeks. Now, some people will point out that oftentimes SSRIs do work faster, but rarely do I see them working in a matter of days, like some of the second generation antipsychotic augmentation agents. So aripiprazole augmentation is something I go to pretty early on if the episode is severe. And I think that's something that is kind of ignored in a lot of treatment guidelines is we have, if you have a major depressive episode, there are treatment algorithms or guidelines for these things, but rarely do they triage based on severity. And if, again, someone's admitted to a psychiatric unit with a recent suicide attempt or severe suicidal ideations, maybe you should be a little bit more aggressive with your treatment than someone who's seeing you in the outpatient clinic who's had a major depressive episode for 3 months and now they're just finally deciding to come and see you. So in general, there's augmentation with second generation antipsychotic agents. There's augmentation with lithium. There's switching to another antidepressant. There's transcranial magnetic stimulation. There's ECT. There's IV ketamine and intranasal ketamine. And at some point, I'll talk more specifically about those later. You've obviously got psychotherapies that should be considered, especially when there's a lot of psychosocial factors involved that may be driving this. So I guess the main thing that I wanted to talk about was really triaging based on severity and how treatment-resistant depression doesn't really tell you a whole lot. I think more important is the time course, the severity, how functionally impairing it is, and their medical history. So you got someone who's really severe, they're pretty low risk medically. Maybe you should consider reaching directly for those second generation antipsychotic augmentation strategies to move things along faster. And then you could maybe think about taking those away. Kind of similar to often how we treat mania in the inpatient setting. We often start an antipsychotic plus a mood stabilizer. And then, especially if there's psychotic features with the manic episode. And then as the person goes back into euthymia in the outpatient setting, you might pull off that antipsychotic and just keep them on the mood stabilizer. So, again, we're used to being kind of aggressive with dual treatment for a manic episode because it's so severe, but we're often less aggressive when it comes to depression. Let's see. Anything else I wanted to say about that? I think that's about it. Um, I'm excited about the SAINT protocol, the Stanford Accelerated Intelligent Neuromodulation treatment for depression. Uh, and there's even some 1-day protocols for TMS that are coming online that I think will dramatically improve accessibility for TMS. Overall, I'm generally very bullish on TMS just because it's a more precise treatment in a lot of cases, or it can be, has the potential to be a more precise treatment, and has very few side effects. So I'm generally pretty optimistic about that, although these things take a long time to develop. So I've got more to say on each of the things I kind of touched on today. I'm sure I'll do a episode just on ECT and just on ketamine and just on some of these medications. But that's kind of what I wanted to say about treatment-resistant depression for today.